Okay, so here are my disclosures. Key is I've trademarked a number of terms. I have several books that I've published and have equity interest in those companies. Here are the objectives. I'm going to bypass that. Now, before I entered medical school, I was an athlete. I competed nationally in full contact taekwondo, where you get 2 points for kicking people in the head. And once I entered medical school, I decided that was not a good sport to be in. So I completed medical school, residency. I had a couple of kids, and things were going really great. And then in 2000, I became a patient. I had a left leg weakness. I had, during that workup, my neurologist noted a prior history of visual dimming in my left eye 13 years earlier. I had one lesion in my spinal cord at about C3 and another one in my brain. I had abnormal spinal fluid consistent with oligobands, and a diagnosis of relapsing remitting MS was made. Now, this, as you know, MS is a very costly disease. The DMTs exceed $90,000 a year. And we have many, many DMTs, but the cost of these drugs continue to rapidly escalate. And then you have the MRIs, labs, therapies, office visits. And within 15 years of diagnosis, half will exit the workforce due to fatigue disability, and 30% will have gait disability. And most will convert to secondary progressive MS or progressive relapsing MS. And that usually occurs between age 45 and 55. Now, in 2000, when I'm diagnosed, I'm 45 years old, and you could take interferons or Copaxone, which is a decoy protein. And once you convert to secondary progressive forms, it's relatively resistant to therapy, and then you're treated with chemotherapy. And if you in 2000, if you had primary progressive MS, there was no treatment available. Now, we've known that from the observational studies, not only for MS, but really for any of our NHANES data, patients are not eating the governmental recommendations for vegetable and fruit intake. 80% have less than 3 servings of vegetables and fruit per day. And this is from George Jelinek. When they looked at a quality of life for the dietary habits screener, and the more nutrient-dense diet had higher quality of life, higher mental quality of life, and a reduced risk of disability. And then if we look at dietary inflammation index, this is something that we use to study observational studies. They looked at whether or not a particular dietary parameter, and I'll go over those, either increased inflammation, decreased inflammation, or had no effect. And we're looking at a number of inflammatory cytokines. So the minerals, iron, magnesium, selenium, zinc, the vitamins, retinol, vitamin A, the B vitamins, vitamin C, vitamin D, vitamin E, the fats. Now, trans fats is really a problem. And then the red color are the carotenoids. These are the deeply colored pigments in our food. The yellow-orange are the spices, and how much alcohol you're drinking, how much caffeine you're drinking, and how much green tea you're drinking. It's been used in hundreds of observational studies. And the most anti-inflammatory diet has a score of negative 8.87. The most inflammatory diet has a positive score of 7.98. And it's really high in added sugars, processed foods, really the westernized diet. And the DII score correlates with the risk of all of these chronic disease states. Now, humans began in equatorial Africa, and we begin migrating north to Northern Africa, the Middle East, Europe, Asia, Australia, the Pacific Islands, North America, and eventually South America. And we thrive eating the foods in each of these ecosystems, including ecosystems that are in the Arctic with very little plant material. Now, when you look at a diet study, they're hard to do. You're going to ask people to give up familiar foods, eat new foods with unfamiliar tastes, recipes, menus. They'll probably crave foods that are now excluded. They may not know how to cook or shop or meal plan. And they're going to have peer pressure to eat the foods we've told them to reduce or eliminate. And recruitment and retention into diet studies is hard. And I'll tell you, because people know if they're in the control arm, the intervention arm, nobody wants to be in the control arm, and it's hard to keep those control arm people in the study. So Roy Swank had the theory that a high saturated fat diet accelerated neurological disease. And he had a dietitian come into his clinic. He trained people on a low saturated fat diet. There were 264 people that he started following originally. There was high attrition over time. That was probably not random. So he ended up with 144 people that he followed over 50 years, not blinded assessors. And he compared less than 15 grams of saturated fat to greater than 15 grams over the 50 years. The greatest benefit occurs earlier in the disease course. And if you followed the low-fat diet, you were more likely to still be walking, still employed, and there was a lower all-cause mortality. Now, in 2002, my treating neurologist told me about the nonprofit Direct MS that advocated for the work of Lauren Cordain in the Paleolithic diet. After 20 years as a vegetarian, I adopted the paleo diet. So I gave up grains, legumes, and dairy. The following year, I needed a tilt recline wheelchair. I was 48. My physician told me I was in the secondary progressive MS phase, and that I should treat my disease aggressively because functions once lost would not come back. And during that time, I started reading the basic science. I began experimenting on myself. I developed the theory that mitochondrial dysfunction is what's driving disability. And I start taking a number of supplements to support my mitochondria. It maybe slows my decline. I can tell if I take my supplements, my fatigue is a little bit less, but I'm certainly still fatigued. By 2007, I cannot sit up anymore. I have a zero gravity chair, one for my home, one for my office. Fortunately, I'm still mentally clear. I'm staffing the resident clinic. I'm in the institutional review board reviewing research. And I say, give me the studies related to the brain, because those are the things I want to be reading about. I discover a study using electrical stimulation of muscles for people who are paralyzed, who are never going to walk again. And I talk to I do a search. I look at all of the studies. There are 212 that are published. I look at all the abstracts. And I talk to my physical therapist, and he agrees to give me a test session. Of course, it's not approved for MS, but is approved for muscle spasm, disuse, muscle atrophy, and decreased range of motion, all of which I was afflicted with. So we add the electrical stimulation of muscles to my little tiny mat exercises that I've been doing. Then a couple weeks after that, I discover the Institute for Functional Medicine. They have a course on neuroprotection. I look at the faculty. I decide it looks like a good course. I order it. I take this course. I have a longer list of supplements that I can now add. And then I have this really big aha. Like, what if I redesign my paleo diet to maximize the nutrients that I'm taking in pill form for my mitochondria? And so I restructure this new way of eating December of 2007, December 26th. And for context, at that point, it's very clear I'm going to have brain fog. I'm probably on track to become bedridden by my illness, possibly demented by my illness. And because I have trigeminal neuralgia, possibly dying with intractable trigeminal neuralgia. Certainly a very difficult future. As I said, I've discovered the functional medicine. I'm really focused in on these environmental factors. And I've already been doing exercise, electrical stimulation. I finally begin to go back to doing some daily meditation, and I am redesigning my Paleolithic diet. And in doing that, I'm able to, in the period of 1 year, go from being able to take just a couple of steps with my 2 walking sticks to walking easily in the neighborhood and doing an 18.5-mile bike ride with my family, which really transforms how I think about disease and health. And then my chair of medicine at the University of Iowa, my chief of staff at the VA, call me in and they want me to do a safety and feasibility study to see if others with progressive MS could implement this complicated program that I'd use for my own recovery. So we start doing this. We enroll our very first person in 2010. It's a single-arm study. We have blinded assessors, and we're asking, could other people with progressive MS do what I did? Do we have serious adverse events? And what's the effect on fatigue, quality of life, motor function, mood, cognition, and blood lipids? So we're going to ask people to stop ultra-processed foods, added sugars, white flours, gluten, grains, dairy, and eggs. We stress more vegetables, 3 cups of leafy greens, 3 cups of deeply colored vegetables and fruit, 3 cups of sulfur in the cabbage, onion, mushroom family, and that's measured raw. If you're petite and small, you don't have to do 9 cups. We don't want people to eat beyond what they can tolerate according to their appetite. We encourage grass-fed meat, organ meats, liver once a week, wild fish, according to their budget. We wanted at least a minimum of 4 ounces of meat every day or fish. We encourage fermented food, as in sauerkraut, kimchi, seaweed once a week, nutritional yeast, and algae. This is sort of an example meal. Because this was a restrictive diet, I needed to do a 24-hour recall on my diet to verify that it was safe. So this is 24-hour recall, 2 weekdays, 1 weekend. The maroon is the NHANES data from the US for women age 50 to 70. The blue was me. And so I was given permission to go ahead and do the study. We also had people take methyl B12, methylfolate, vitamin D, and fish oil. Again, so we have the dietary changes. We teach a mantra-based meditation, some stretching, an exercise program, and electrical stimulation of muscles. We had 20 people, 12-month intervention. The risk was if you're overweight or obese, you lost weight without being hungry. One had to be withdrawn at 6 months due to continued cognitive decline, which was attributed to the progression of her illness. The adherence to interventions, people radically change what they're eating from baseline and they keep it up over the whole study duration. We get up to an mean of 8 servings of vegetables per day. From the public health perspective, that would be a phenomenal success because if you can increase fruit and vegetable intake by 1 serving a day, that's considered a phenomenal success. On the right is the level of disability was between cane and walker. And so people began exercising. They could also put on electrical stimulation and just ride the current. So they exercised and also did additional electrically driven exercise as well. The top 2 lines are short form 36, general health and energy. So that improves 14 to 17 points, and a 5-point improvement is clinically significant. The bottom line is fatigue severity scale. 0.45 is clinically significant, and that's a 2.38 improvement. We have improvement in the anxiety and depression scores. And as you know, anxiety and depression increases the longer you have multiple sclerosis. On the right is verbal and nonverbal reasoning, which also improves over time. And to put in context, you anticipate a 10 to 15% worsening for each of these disability scales each year for people with MS. The associations between baseline and 12-month values in terms of the adherence and how well the mood improves, verbal reasoning, or fatigue improves. Eating more vegetables and fruit, very helpful. Avoiding the excluded foods, also very helpful. And then people might say like, oh my God, you eat all this meat, we're going to make the lipids worse. Actually, what I'm showing you is the mean body mass index goes down, total cholesterol goes down, triglycerides go down, the good cholesterol HDL goes up, the ratio of triglycerides to HDL goes down, and that's a marker for insulin sensitivity. So that's improving. I give a TED Talk November 11th of 2011, which leads to a book deal, the Wahls Protocol, which comes out in 2014, March 14th. The National MS Society and probably neurologists all over the country have a lot of the patients asking about that doctor in Iowa. What about diet? In the MS Society, monitor social media to know what their constituents are saying. And they see that there is this robust conversation about diet, exercise, vitamins. And so this really is in response to my book. They have a wellness conference and make diet, exercise, stress reduction, wellness research a priority. And so I'm one of the folks who are submitting proposals to study diet. And we do a proposal comparing a modified Paleolithic diet and a low saturated fat diet. And the study design is that people come in, they get baseline assessments. We ask them to eat their usual diet, come back in 12 weeks, repeat the assessments, randomize them to either the Wahls diet, the modified paleo, or the low saturated fat swank diet. They got 5 calls with the registered dietitian. They come back 12 weeks later, and then we follow them without support calls for another 12 weeks to see if can they sustain this. And so here are the results. Fatigue severity scale reduces at 12 weeks, further reduces at 24 weeks. Statistically, Swank and Wahls reduce equivalently, but it's significantly reduced compared to the observation period. The modified fatigue impact scale, which is more sensitive, reduces at 12 weeks, further reduces at 24 weeks. Now, at 24 weeks, the Wahls is significantly more reduced than Swank. The MS quality of life 54. Both Swank and Wahls improve at 12 weeks, Wahls significantly more so. At 24 weeks, they improve further. Wahls is still significantly more improved than Swank. Mental quality of life, Swank doesn't really improve at 12 weeks, Wahls does. They're significantly different. At 24 weeks, Swank does improve, Wahls improves further, and Swank and Wahls are still different at 24 weeks. The 6-minute walk test is a measure of how far you can walk in 6 minutes. Neither one changes. And we should not be surprised by that because we ask people to not add an exercise program unless their physician specifically prescribed that, because this is a diet study. What is super interesting, at 24 weeks, the Wahls group walked significantly farther with a p-value of 0.007. However, and Swank improved a little bit as well. The difference between Wahls and Swank is a trend at 0.08, not statistically different. Simple digit modalities test, Swank improves at 12 weeks, Wahls does not. P-value 0.08, so there's a trend there. That's statistically different. At 24 weeks, Swank and Wahls are equivalent. So the bottom line is improving your diet, whether it's a low-fat or a modified paleo diet, leads to reduced fatigue, improved quality of life. And Swank is better for some measures, Wahls is better for other measures. The registered dietitians are going to have pushback to paleo diet. They want nutrients with an established recommended daily allowance. They're worried that excluding whole food groups increases the risk for nutrient insufficiencies. And any diet not following the USDA dietary guidelines is called a fad diet. And they think that a paleo diet, because it doesn't use enriched flours, will be low in thiamine, pyridoxine, and folate, low in calcium, and if you're reducing eggs, low in choline. Now, we have done diet analyses of the modified paleo diet on several of our studies. We had 19 participants with progressive MS, that first day I showed you, and we had 1 year of food frequency questionnaires. We had 38 participants from the WAVE study with 24 weeks of weighed food records, and they also had FFQs. And for analyses, whether you're looking at food frequency questionnaires or weighed food records, we saw that diet quality is improved from baseline or observation at enrollment to the intervention period. However, the modified paleo diet is low in calcium and low in choline. So my clinical practice, I suggest take supplemental vitamin D plus K2 and a multivitamin, multimineral. If you have a vitamin D in the top half of the reference range, that increases intake in the calcium. And if you have a lot of greens, that is a richer source of calcium and of magnesium. So a secondary analysis of the WAVES trial, looking at MS functional composite, that combines the 9-hole pegboard, 25-foot walk test, simple digit modalities test into a single score. We looked at 12 weeks of observation, the run-in and baseline values, and 24 weeks of intervention, so week 12 and week 24. The SWANK had a score of 0.13 that improved to 0.10 at baseline and then to 0.14 at 24 weeks. Wahls doesn't change at 12 weeks. So it's at 0.10. It increases to 0.28 at 24 weeks for a p-value of 0.002. 9-hole pegboard's a hand function, and working memory increases at 24 weeks. And no statistically significant difference between groups at any point. And furthermore, the changes in MS functional composite and 9-hole pegboard are mediated by reduced fatigue. Then we did two randomized controlled studies of a modified paleo diet. In study 1, the paleo group, a significant reduced disability with better MS functional scores, 9-hole pegboard, and PASAT at 12 weeks. In study 2, where there was more secondary progressive MS patients, the control group worsens and the intervention group remains stable. So, my take on that is the earlier that you make these changes, you can improve function. Or that if you're more seriously disabled, it will take longer than 12 weeks to improve function. This is a non-inferiority study, quasi-experimental. Newly diagnosed clinically isolated syndrome in which DMT was recommended, or relapsing remitting MS in which a DMT was recommended. We had 29 who choose to decline DMT and were trained on a modified paleo diet, a walking program, and a breathing meditation. That's a misspelling there, breathing meditation. and 25 had standard DMT use. They got to eat and do whatever it was that they wanted. And we measured fatigue, quality of life, mood, and cognition. The non-inferiority analyses demonstrated that a program of a modified paleo diet, daily walking, meditation was not worse than standard DMT use for the following: fatigue severity scale score, HADS for anxiety and depression, physical quality of life, and cognition as measured by perceived deficit questionnaire. Okay, we've already gone through that, so here's a web-based course, Quality of Life and Fatigue. This is a commercially available online wellness course. AIM has 5 modules, multiple lessons in each module. It's web-based. There was no ongoing support. People either got access to the course, they had to wait to get access. We had 100 folks. It's a 24-week study, waitlist control. At 12 weeks, the control group gets access to the AIM course. And you can get the course at terrywahls.com/AIM. There's a conflict of interest management plan in place. I had no access to the participants, and a math statistician did the analyses. The intervention group is compared to the control group, and we had significant improvements in quality of life, significant reduction in fatigue, as measured by modified fatigue impact scale and fatigue severity scale. And so access to the AIM course, an online program, improves quality of life and reduces fatigue. So diet. Well, I'm not the only one that studies diet. We did what's called a network meta-analysis. And this is a statistical way of looking at multiple studies, and it allows you to rank order the effectiveness. This is how we rank order the effectiveness for disease-modifying treatments, for antibiotics, for diet interventions, exercise programs. So it was done in May 21, randomized trial with a diet intervention, adults with the definitive multiple sclerosis based on McDonald's criteria, a patient-reported outcome for fatigue or quality of life in at least a 4-week intervention. 12 studies, 8 diets, 608 participants, low fat, Mediterranean, ketogenic, anti-inflammatory, Paleolithic, fasting, calorie restriction, control or usual diet. And we used the descriptions of the diet that matched the researcher's description of the diet. This is the forest plot. When you look at fatigue, you see 0 and negative numbers favor the intervention because you want fatigue to go down. The horizontal line is the 95% confidence interval. The gray box is the mean and standard deviation. You'll see that there are 3 diets that the 95% confidence interval favors the intervention: Paleolithic, low fat, Mediterranean, and that the paleo diet is about 40% more effective than either low fat or Mediterranean. And then for physical quality of life, Paleolithic and Mediterranean are the 2 that are most effective. And again, Paleolithic is about twice as effective as Mediterranean. And for mental quality of life, Paleolithic and Mediterranean are the 2 that are most effective. And Paleolithic is twice as effective as Mediterranean. I want to highlight, though, that exercise is also important. In our first study, which is multimodal, we combined diet, exercise, supplements, stress reduction. The goals for exercise are 150 minutes of moderate intensity every week, high intense. And when I talk to my patients, I let them know that high intensity means you can't speak or sing. Moderate intensity, you can speak but not sing. Low intensity, you can sing and speak. So, running hard, walking briskly with a rucksack, moderate would be high intensity. Moderate intensity, a brisk walk, easy jog. Low intensity might be yoga. And the goals are each week to include stretching, balance, aerobic, and strength training. And we should be doing this for our patients, even if severely disabled. And the people in my progressive MS study were certainly severely disabled, with the mean disability between cane and walker. So I ask my patients to start slow, have a variety of things that they do, and it should be things that they enjoy doing. So I'm just going to show you one exercise study, which was a meta-analysis, 5 exercise therapies on quality of life. Looked at aerobic resistance, a combination of aerobic plus resistance, sensory motor training, which is balance training, mind-body exercise, and control. A lot of studies, almost 2,500 participants. The largest effect size, super interesting, that was on the balance training. And for quality of life, specific to physical health, mental health, aerobic and mind-body exercise also did well. If you had mild disease, the balance training was particularly helpful. And more severe disease, aerobic training was particularly helpful. When I'm teaching to other clinicians, I warn them that you can't stop DMTs abruptly because you're going to have a rebound if you do. And that I want people to have 36 months of no new lesions and no relapses. Then we can transition to a less potent DMT with fewer side effects. And depending on the age, they may be able to get off DMTs entirely. I acknowledge that changing dietary patterns is hard. The World Health Organization notes that 25% of patients will begin a diet change recommended by their medical team. At 24 months, only 2.5 have still sustained the diet change. And the standard American diet, westernized diet, is increased the risk of all of these chronic diseases that we now face. It's hard because our brains are wired for pleasure. We value immediate over future, fear of loss over the current benefit, and our habits are automatic. Our biology has us craving salt, sugar, fat, and sex. That's served us over millions of generations. We crave pleasure, we crave comfort, we crave inactivity, and we avoid pain. Food addiction is real. Tobacco industry purchased the food industry, and they have used their scientists to create addicting products, such that withdrawal symptoms often occur as people attempt to reduce or eliminate the sugar in ultra-processed foods. How do we help change our diet and lifestyle? I've created a behavior change model that has 15 steps based on what I learned from my patients at the VA, my own healing journey, the research, the health psychologist, and the addiction specialist that I worked with. We talk about the inspiration of relatable stories. We want to help people grow their motivation to do the work, to be willing to put up with the discomfort. So what is your why? What do you want your health for? If your home was beginning to have some smoke rolling out of the window, is there somebody that you would rush in to save? Whether it's your children, grandchildren, your spouse, your dog, and what would you like to be doing with that person or your pet again if your health improved just a little bit? Then we talk about facilitators, how we can facilitate to make the choices you want to make easier to make, how you could put up barriers to make the choices you want to do to stop making poor choices harder? I was at the VA, the Veteran Affairs Hospital here in Iowa City for many, many years. And the chief of medicine, and then ultimately the chief of staff, asked me to come out of primary care and create a new clinic that utilized the concepts that I had learned and was now using in the traumatic brain injury clinic. We called it the Therapeutic Lifestyle Clinic. And the target was people with complex chronic disease. I first went after people in the pain clinic. I went to the pain clinic, to specialty medicine, primary care, and I said, give me your most difficult pain cases. They should know that I'm not giving them drugs. We're going to be working with lifestyle issues to help them better manage their pain. And people came with a wide variety of diseases. Many of them had diabetes, obesity, they had war injuries, they may have autoimmune problem, they may have anxiety, depression. They're often on 15 to 30 different prescription meds. Again, anxiety, depression, bipolar, PTSD, very common. I'd say about a quarter of the folks had an autoimmune diagnosis as well. And then when we asked them what were the symptoms that were most troublesome, so many, many different diagnoses, the symptoms that had the biggest impact on their lives were fatigue, pain, brain fog, anxiety, depression, irritability, difficulty getting along with their spouse, their family, and their coworkers. Now, when I got going in this clinic, I couldn't do any fancy functional medicine type testing. What I could do was some basic primary care stuff: lipids, vitamin D, homocysteine, B12, folate, hemoglobin A1C. I would eventually add an insulin. And we focused on modifiable lifestyle factors. Exercise, had people get a step counter and just start writing down every day how many steps. We talked about how to improve nutrition and diet quality. I invited a gluten-free vegetarian diet or a paleo diet. Gave them vitamin D. I can only give them 2,000 units, a multivitamin, multimineral, and a B complex vitamin. Very basic supplements. We taught them a stress management. We talked about Epsom salts. We talked about 4-7-8 breath work. Talked about taking Epsom salts before going to bed and trying to have a consistent bedtime and getting up time, going outside and getting some daylight early in the day, getting connected with people face to face. And could we help them find purpose and meaning in their life? This is where that question is, who would you save from a burning building? And then we tracked their biomarkers, their weight, their blood pressure, their fatigue, their quality of life. Now, with minimal testing, we saw really remarkable transformations. In my clinical trials, about 30% don't respond to diet interventions. A 70% response rate, though, is still quite remarkable. In the therapeutic lifestyle clinic, I could get it up to 80%. Was it poor adherence? Were there other factors? Could I personalize the intervention even more if I did a little more thorough investigation? So what I'd advise to you and what I'm teaching is send people to nutrition professionals, health coaches, physical therapists, exercise classes, in the primary care integrative team so they could support that behavior change because it's hard work. And then, depending on the medical comorbidities, the mental health issues, anxiety, depression, do they have sleep quality with restless leg syndrome, periodic movement disorder, obstructive sleep apnea? Do they need a sleep study? Do they have insulin resistance, obesity, metabolic syndrome, type 2 diabetes? What are their lipids? Do they have high blood pressure? Then that will guide, am I suggesting a Mediterranean diet, a paleo diet, a ketogenic diet? Ideally, a detailed health and exposure timeline. If you can, this more comprehensive look at nutritional status. You could do genetics, food sensitivities, microbiome, toxins, heavy metals, infections. Now, keep in mind, so you could spend easily thousands of dollars and be overwhelmed with the amount of data. The vast majority of improvement you can get with basic primary care labs and a health coach and nutrition, physical therapy to really dial in the modifiable lifestyle factors. We have a study that we're doing. I'm very excited about it. The efficacy of diet on quality of life. We recruited people age 18 to 70. We actually got 162 people in. We're comparing a ketogenic diet, modified paleo, usual diet. We have quality of life, the MS functional composite. We have MRI at the beginning, at the end. It's a 2-year study. So it's really going to be the largest, longest diet study with MRIs. Our last study visit will be July 2026. So 2027, we'll be presenting this data. I have active trials right now. Please send your people to terrywahls.com trials so they could be part of our patient registry. We want people with autoimmune, neurologic conditions, chronic health issues. We have an online wellness course for people with fibromyalgia, long COVID, and we will soon be adding rheumatologic autoimmune disease, anxiety, and depression. And I'm hoping this will transmit well. This is a video from the progressive MS study. She has secondary progressive MS. She's going to, if you watch, she's having a hard time bringing her feet forward. She's dragging her toes along. We're nervous about how she's doing, so we're chasing her with the chair. And it takes her 124 seconds to walk 8 feet, turn around, and sit down. Now, the first time we could see improvement for her is at 9 months. And you see how easily she stands. And just look closely at how easily she's moving her legs forward. Then here's subject 11. She has secondary progressive. She needs a cane for short distances, walker for long distances. Now look closely at her feet. You'll see that she's in Birkenstocks. Her gait is almost normal. And at 11 months, she's jogging. Subject 14 is very stiff with 2 walking sticks. And he's improving at 9 months. And then he, again, has improved enough he can walk without canes at 9 months. And subject 17 has primary progressive MS. She's quite stiff, 2 canes. And we see improvement with her in 3 months. Here she is with 1 cane. Yeah, and without. So the key concept, most effective diet for fatigue, Paleolithic, Mediterranean, low fat. For quality of life, Paleolithic and Mediterranean. The modified Paleolithic diet is insufficient in calcium and choline. Vitamin D in the upper half of the reference range increases calcium absorption. Multimodal interventions address nutrition, exercise, stress, sleep, social connections. You want to think about the medical comorbidities, metabolic health, underlying mental health, anxiety, and depression. You can send people to terrywahls.com trials. They could go to my website for more information. Follow me on X and Facebook at Terry Wahls. Follow me on Instagram at Dr. Terry Wahls. You get to see what I'm eating and doing. And with that, I'm stopping because I believe we have hopefully a bunch of questions.
Thank you, Dr. Terry Wahls. There's nothing like seeing those videos to believe. And I encourage everybody who's watching this to go and see Dr. Wahls' TED Talk as well for more inspiration in a short chunk of time. Um, so we have some questions here. So the first
Great.
one, and I know that you address this a little bit, but maybe we can dive more deeply into it, is have you seen such dramatic improvements with the Wahls diet, this modified
Oh,
paleo diet, in other autoimmune diseases?
so I'd like to comment on that. People often say, my physicians must have made a terrible mistake. I could not have had progressive MS and recovered so remarkably. So I think it's really important to know that we have had other folks who were every bit as bad as I am. I think of this one lady from Canada who had great difficulty transferring from independently from her wheelchair to toilet, wheelchair to bed, who implemented the concepts that I teach. She took online classes with me multiple times. In over a 3-year period, she got so she could stand again, take a few steps with her walker again, start walking with her walker reliably, start walking with a cane reliably, start walking without a cane, and having little bits of jogs. So she's hoping to be able to take her dogs on the beach again. We've had other individuals, likewise, who are wheelchair dependent, using the concepts that I teach, including electrical stimulation of muscles, recover enough that she was able to walk her son down the aisle at his wedding. And there's a beautiful video of her dancing with her son at his wedding. It is possible. It takes a huge amount of work, time, and commitment. We've seen this be very helpful for inflammatory bowel disease, rheumatoid arthritis, Sjogren's. We've seen it to be helpful for Parkinson's. We've seen it to be helpful for anxiety, depression, helpful for people with type 2 diabetes and obesity. So, yes.
Okay. Yeah, and I'm glad that you went in, because one of my questions was going to be that sustainability and ability to stay with a diet, and that is, somewhat restrictive. And I know you address that a lot about how you have found ways to keep people engaged
You
and
know, what our people tell us, uh, and I think it's in most dietary studies, people will regress back to their previous diet unless so doing increases their symptoms.
right.
So what our people tell us is when they go back to their previous diet, had pizza and beer with the girls or the guys, and their migraines come back or their optic neuritis comes back, that's a very strong signal like, I'm not doing that again.
Oh yeah, right.
So I have trigeminal neuralgia. If I if I come to your house, Dr. Ring, and you serve me gluten, my trigeminal neuralgia would flare up. That's a very strong signal. I'm not doing that again voluntarily. If people can connect, and that's part of what I teach in the Wahls Behavior Change, is to pay attention when you have a flare of symptoms. Look at the previous 24 to 48 hours. What might have been a trigger? Was it a food? Was it a toxin exposure? Was it a fight with your spouse, with your boss? Was it a wildfire? Was it the sugar, the high amount of sugar that you had? And then test that out, like get that, reduce that exposure. And likewise, if you have a great week, more energy, less pain, less stiffness, better vision, I encourage people to go back and say, like, what was it about that week that made it so good? Could you do more of that? And by teaching people to draw that connection between what is making things worse, what is making things better, over time, they will keep refining their self-care into what is sustainable for them.
Can I ask, because a lot of times when I'm counseling patients about diet, about lifestyle, there's this concept of like, 80/20, 90
Yeah.
10, and like, you don't have to be perfect all the time. Is that okay with this kind of approach? Or are you saying
So
like that's where, is
so
it
I am
all
writing
or
a new book.
nothing?
I am writing a new book. We're going to be talking about that at details of the new book. So if you take the standard American diet, about 325 to 350 grams of carbohydrates. Uh, uh, too much sugar, too much white flour, terrible nutrition. If you implement a paleo diet, and Lauren Cardane, who was the champion of that, said do it 80% of the time. So he's allowing for some flexibility. And that will be a huge improvement. If you have autoimmunity, there's a greater probability that you have an abnormal immune reaction to gluten and dairy. So for those people, you'll probably do better if you can take out gluten and dairy. But even if you can't, if I can just do it 80 to 20, you're getting the more nutrients, and that is really good for you. So it's sort of like a Mediterranean diet. It is really good for you. It's way better than the standard American diet. If you can make it eventually to take the gluten and dairy out to see, are you one of the people who are gluten sensitive? You didn't know that? That would be worth sorting out. But if you can't do that in the beginning, then do the 80-20 rule and just improve your diet.
Right. Okay, great, good, and probably reassuring to people to hear that. Okay, a question about medications. Somebody asked, I may have missed this, were any of the study patients on any of the IV infusion medications that modulate the immune
Okay,
system?
that is a great question. And I did not include our control variables. So we kept track of who was on DMTs, what DMTs they were on. Our statistician classified DMTs as highly effective, moderately effective, low effective, and of course, no DMTs. And there's a statistical means to control for that between the two groups. And so, yes, we did that in each of our studies, and we'll be doing that in the study that we're conducting right now, efficacy of diet on quality of life.
And, in terms of DMARD, so this is I personally have a really, I'm interested in your opinion on this, because the way I've counseled people as an integrative medicine, functionally trained physician is, I want you to be we want you to get off those things you are using, so you don't need pain medication, you don't need steroids, things like that. But the DMARDs are disease modifying. So they have evidence for disease modification. So even if we are doing holistic approaches, that doesn't mean you should get off your DMARD.
Well, so what I counsel people is, at least for the MS world, you want what you don't want to have disease activity. So I encourage people, yes, it's fine to take the DMTs. If you can go 3 years, no relapses, no disease activity, no activity on your MRI. And if you don't have MS, but you have another autoimmune disease. So it's a measure of what is the measure for disease activity for that disease? Is it
Mhm.
endoscopy? Is it blood work? Is it a skin exam? So it's 3 years, no disease activity. Then we can transition you to a less potent DMARD or disease modifying treatment with fewer side effects. And
Okay.
and then the question might be, can we take you off DMTs or DMARDs? Maybe, but you would certainly want to follow you very closely. And over the age of 50, the hazards of the disease modifying treatments climb, the benefits decline, and as our immune cells get older, more immunosenescent, they become less and less able to protect us from infection and cancers. So I really like to have people get off the disease modifying treatments. And we don't know, is that age 50, 55, 60, 65, somewhere in there. I think the specialists want them off as well. But you still have to follow them for the disease activity because you may end up putting them back on.
Right. Okay. Thank you. So again, you know, we're not like anti-pharmaceuticals. There's a place for them. It's really a balance in looking at the individual person and what their risks are and what's the minimum that they need to control the
The minimum
disease.
that we need, and at what age does the risk of the DMT outweigh the benefit?
Right. Perfect. Okay. Thank you. Okay. Another question. So great talk, they say. Have you looked at into how the diet might affect mitochondrial function? Since the 6-MWT results didn't show much, it could be interesting to examine interventions that might boost mitochondrial function, such as endurance resistance exercise, photobiomodulation, and see how that affects fatigue and functional
Well,
endurance added to diet.
So absolutely, in my clinical practice, we do all those things. We have people
Okay.
strength train. We have use red light therapy. We talk about sauna and cold plunges. In a clinical trial, um, you do a diet study. The next study I would like to do, and I'll be talking with uh, uh, funding strategies to do a diet plus exercise study in a waitlist control, so we can see the benefit of combining diet plus exercise.
Okay, great. And it's not here. Those were the questions. So I'll maybe since we have 3 minutes, maybe ask one other question. I know you listed like, okay, these are some of the core nutrients that you may want to use as supplements. And
Yeah,
I know I get a lot of questions from patients about other supplements that might be included in a regimen. I know at the beginning of the talk you mentioned like, getting a whole laundry list of supplements. A lot of what you focus on is really those core lifestyle factors. But do you also
so
feel
yeah,
like those other supplements
yeah,
have benefit?
in my clinical practice, I have a
Mm,
longer list of supplements. So in my clinical practice, I want vitamin D plus K2, a multivitamin, multimineral, fish oil, 1 to 4, and I sort of monitor the lipids to figure out how many grams, and then magnesium. The next level supplements, so there's basic 4, next level
yep.
supplements, coenzyme Q, 10. I like activated B vitamins because many of us have, I'm one of them. I have multiple genetic variants that my B vitamin pathways are less efficient. So my
Hmm.
homocysteine was quite high. When I take activated Bs, my homocysteine is at a nice level. So CoQ, activated Bs, and N-acetylcysteine would be the next level.
Okay,
Then people will
great.
ask me about more exotic things like NAD infusions and MNN and urolithin A. And so, yes, you can get a more robust sets of things. And would probiotics be helpful? Yes. Would anti yeast things be helpful for those of us who had early antibiotics? And I'm one of them. Yes, and that's probably why I do better on a lower carb diet because of those early antibiotics that I had.
Great. Okay, thanks so much. Well, I know we're coming up on time, but I've met you several years ago through Mindshare,
Oh,
through this community, and I'm thrilled to have you here as at Northwestern sharing all of your research. So thank you so much for being here.
thank you very much.